Well, happy Monday, everyone, and welcome to another episode of You've Got the Power. I'm your host, Dr. Jason Deitch, and of course, I am here with Chief Medical Officer of the Centeno Schultz Clinic in Broomfield, Boulder, Colorado, Dr. Chris Centeno. Good afternoon to you.
Good afternoon, Jason.
Welcome, everyone. As you know, we are here each and every week at the Centeno Schultz Facebook page going live, answering your questions, helping you understand how to take your power back when it comes to your health, more specifically, when it comes to living and suffering with orthopedic conditions that oftentimes steal your life from you. There's too much misinformation, there's too much wrong direction. And what it is we try to do here each and every week is answer your questions so that you can be well informed on what it is that you need to know about how to make the right choices when treating, healing, and even reducing your risk of these types of injuries. With all that said, our topic for today, our question for today, is what's the difference between prolotherapy, platelet lysate, PRP, and bone marrow concentrate, all different ways of helping the body heal itself. Doc, we get lots of questions about the distinctions between these. Oftentimes patients feel as if they want to come in saying, this is what I want, or this is what I heard will work for me. Let's start off by breaking down what each of them are and how you as the doctor determine which of these technologies is really best for each individual person, patient, injury, and their goals.
Yeah, Jason. So we use these technologies to treat lots of different things, everything from spinal problems, CCI, to peripheral joint injuries, etc. And when it comes to those different technologies, we've got the simplest one and the one that's been around as a concept for the longest, almost a century, is prolotherapy. So prolotherapy is injecting a solution that'll cause a brief inflammatory healing response and sort of giving the body another bite at that healing apple. So prolotherapy works really well with things like ligament injuries. And then we go kind of up a step to platelet-based therapies. And there, the most common one we would see is PRP, or platelet-rich plasma. That's where we take the platelets from the blood and we concentrate those and we put those back, usually through injection. And PRP can work well for everything from knee arthritis to ligament injuries. And the platelets work by sort of energizing the local repair response. From that PRP, you can also lyse or break open the platelets and get the growth factors out. The growth factors are the things that help with that repair response, and that's called platelet lysate. And then finally, bone marrow concentrate is basically taking a bone marrow aspirate, which looks like thick blood, and then taking the stem cell rich fraction out of that bone marrow aspirate, concentrating those nucleated cells and using that to re-inject. So that's a little bit like PRP, but there are stem cells in that mix. And those cells can do everything from direct a repair response to differentiate into the bricks and mortars at the end of the day. So those are the sort of the 30,000 foot view of those three different technologies.
We are getting more and more of you joining us. Welcome to our program and our show. This is an important one because we often, almost each and every week, get questions about, should I be using this PRP or should I be using bone marrow concentrate? And what we're really doing today is breaking down what each of these things are, as well as getting into how Dr. Centeno and how the doctors he's trained think about using each of these technologies. Let me pause for a moment and break down. I've been referring to them as technologies, but I want to really, I guess, want to make more accurate is these are different types of, I guess I'll call them biologics, in that they are made by your body specifically for your body, and they are all autologous, and that specifically means that they come from you yourself. Doc, would you break down the difference between what you know to be autologous stem cells or autologous types of cells versus products out there that may try to sort of slip in under some of these different types of names?
Yeah, so all of the things we mentioned, obviously prolotherapy is just an injection of a chemical, so that's not autologous. PRP is autologous. Bone marrow concentrate is autologous. Autologous means it comes from your own body. And then we see a lot of things being sold out there, usually birth tissue derived, which are not autologous, meaning that they come from someone else's body. Usually that's umbilical cord products or products derived from amniotic tissue. And regrettably, while those may or may not have growth factors that can help with some healing, those are not live cell products. Those products all are dead cell products. In fact, we just had a major paper accepted for publication in the American Journal of Sports Medicine on that topic of umbilical cord products, where 6 different companies all claimed that their umbilical cord products had live mesenchymal stem cells in them. And turns out that after doing research in our lab and up at the Colorado State University Translational Medicine Institute, not a single one of these products had any live stem cells in it. So just buyer beware out there, focus on what comes from your own body, because that's the thing that's most likely to be safe.
It's so essential, I think, to make sure you're hearing what Dr. Centeno was saying, that we're all enamored by technology. We're enamored by, science and these things that scientists are theoretically able to create. And yet, I guess I'll ask you, instead of saying it, what do you notice to be the difference between using natural healing methods? Basically, again, to me, when I think of it, the ultimate in personalized medicine is your body personalizing exactly the type of blood or stem cells that needs to be specially created specifically for my body, or somebody else creating it for their body. What do people need to know? We have somehow learned to think that nature's not as smart as, quote, science or scientists. What's your experience with all of that?
Yeah, listen, your body developed the ability to heal itself over extremely long periods of time. And the body got to try and test lots of different things during those time periods. So the body's pretty good at healing itself. Now, sometimes it needs some help, and that's what these procedures do. So we take something that would normally help you heal, but isn't getting to the spot or can't get to the spot in high enough concentrations, and we concentrate those things and then place those exactly at that spot. Now, we can also use medications, or at least in theory we could. Right now, there really aren't many tissue healing drugs on the market that we can use. In fact, most everything goes the other direction. It's in the direction of things like suppressing inflammation, which can suppress repair. But we will eventually see healing type drugs, at least when it comes to tendons, ligaments, joints, etc., come onto the market that are FDA approved. But until that time, the best thing you've got is really what's in your body, taking that, concentrating that, and placing that at different areas using very, very specific types of sophisticated guidance.
If you really want to understand how to take your power back, you're going to really listen to the nuance of these conversations. When it comes from you, it is going to be designed for you. But the other part in what you mentioned was the word healing. And unfortunately, when it comes to most of modern medicine, their focus isn't as much on helping the body heal itself as much as it is in suppressing the symptom or killing the pain. And that goal or that outcome has everything to do with what methods and methodologies you use to accomplish your specific goals. Would you take a moment and explain really what you've seen to be the difference between those doctors that focus on killing the pain through things perhaps like cortisone shots or worse, and those doctors that are really helping the body heal itself, as in repair the injury, correcting the cause, therefore allowing the symptom to actually sort of go away, because a symptom is really a body signal. It's the body's way of signaling to you something needs attention. Your thoughts on the difference between the two and why it's so important for people who go to their doctor to sort of say, hey, I'm looking for either temporary symptom relief at whatever cost, and I don't mean financial, I mean biological cost, versus I'm really looking to find out how I can naturally help my body heal itself. What information does that give the doctor, and how might that help a person's different journey along the way?
Yeah, listen, 99% of modern pain management techniques are really focused on suppressing the pain rather than helping to initiate some sort of recovery. And the same thing with surgery. We don't really have healing surgeries per se. We have surgeries that cut things out, move things around, or add hardware to fuse things together. And almost always after those surgeries, the biomechanics, the natural biomechanics are altered. And when it comes to pain management, as you said, many times in the spine, we can inject steroids. The problem with steroids is that can inhibit healing. On the other side of that, we can also do things like radiofrequency ablation, where we kill the nerves that take pain from a specific joint. The problem there is that the joint then has no ability to detect pain. So as you might imagine, that joint is more likely than not to get worse over time because it can't protect itself. So regrettably, the solutions we've put together to control pain in the 1.0 version, if you will, aren't all that great. Now, the 2.0 version would be trying to help your body repair itself, or to try to get the area to heal, or at least to try to not damage the area while we mitigate the pain. And that's a completely different approach that takes a completely different educational background. Doctors who are used to doing things like injecting steroids need to be completely retrained to do this type of work where we try to help things heal.
So important. I hope you're all getting these nuances. Let's head on over to some questions. We're talking about the differences in the type of biologics available for you when you go to one of the Regenexx offices or any of the doctors that are really specializing in what is today known as regenerative medicine. You may also hear it known as orthobiologics. Petra, regular viewer, hi Petra, she asks the question, do you ever use both PRP and Prolo during the same procedure?
Yeah, it's interesting. You really can't mix prolotherapy with anything else that has a live or whole cell. Now, we've seen some folks try to do that, but they've got no science to back up what it is they're doing. And just to give you an example, we did this experiment, God, at this point, 10, 12 years ago, where we took a prolotherapy solution, we exposed it to live mesenchymal stem cells, and even at very low concentrations, it killed the cells. If you expose prolotherapy solution, for instance, to PRP, you've got whole platelets and you've got a concentrated solution out here. So you end up with platelet raisins, meaning that the water gets sucked out of the platelet into the surrounding concentrated solution, and the platelet just kind of shrinks up and becomes dysfunctional. So you wouldn't want to combine a prolotherapy solution with whole platelets or live cells. Where you can combine a prolotherapy solution, based on our research, is that you actually can take the growth factors out of platelets, make what I was talking about before, a platelet lysate, and that can be combined with a prolotherapy solution. But you can't combine a prolotherapy solution with platelets, whole platelets, or PRP, nor can you combine it with any live cells.
That is a great question. Thank you, Petra, for asking and for that distinction. This was asked in advance by Linda Barnes, who asks, can CCI be treated effectively with prolotherapy?
Not how prolotherapy is performed, at least not based on what we have seen through the years by most providers. So what I mean by that is you can't go ahead and inject the ligaments at the back of the neck and effectively treat most CCI patients. you've actually got to inject the ligaments that directly hold the head on, and those are only accessible from the front in that highly specialized procedure. Now, it's a very good point to bring up because we've got a lot of providers out there who are telling CCI patients that they can cure them with traditional prolotherapy in the back spinal ligaments. But we've seen very, very few patients who have gotten relief that way. And, many times, interestingly enough, they're not just doing this once, twice, or 3 times, but we're seeing them go back 8, 10, 12 times to get the same treatment. So they're burning through tens of thousands of dollars of whatever limited resources they have that they may need to use to eventually get a definitive treatment with very little effects that are positive. So no, you generally can't treat that condition that way.
This is exactly why we do this program, is so that you can ask these types of questions. There is a lot of misinformation out there. There just is. And you want to learn for yourself. How do I know what to believe? How do I know what makes sense? How do I know which direction I should go? And if you already know, then you may be friends with or family members with or know someone who's suffering from these conditions. Ask them the same questions. And it's one of those, once you see what we're talking about here differently than the traditional methods of just killing the pain, you recognize that healing is a different pathway and it's available here. So if you know someone who is suffering from these conditions, please invite them to come join our program and ask their questions. Speaking of, Megan May, regular viewer, hi Megan, says, is it possible for ligaments to tear away from bones?
It is possible for that to happen. That tends to happen more in things, for example, like some very, very severe ankle ligament injuries, where the bone actually usually breaks before it separates out from the ligament, for the ligament tears away from the bone. So basically the bone breaks, or the end of the bone is broken off. Now that's a tiny fraction of all ankle ligament injuries, but that can happen. When we're talking about, for instance, the ligaments that hold the head on, generally that doesn't happen. That's an extremely rare thing, even for patients with pretty significant CCI. Other types of injuries where we see ligaments get injured, like knee ACL, generally it's possible for the ligament to get torn off the bone, but generally the ligament gets damaged more in the middle.
Great question. Thank you for. Ben Robertson asks the question, what are the main differences between the above the atlas versus below the atlas PICL procedures? Does the above the atlas injection have the potential to have better results than the below the atlas injection? Thanks very much.
Yeah, so what we're talking about here is in the PICL procedure, where we are injecting the ligaments that hold the head on for patients with CCI or craniocervical instability. There's really 2 ways to do that. One is to go above or below the atlas. Now, when we first started doing the procedure, we went below the atlas. That allows us to inject the lower portion of the alar ligaments, the transverse ligament, and the accessory ligaments, as well as some of the ligaments in the front. More recently, we've been adding the above atlas procedure. And at first when we started to add that, we really didn't know what the safety matrix of that was going to look like. Looks like it's pretty similar to the other one, so that's great, meaning very safe so far. And as we've gotten more experience with it, what we have learned to do is to inject the upper portion of the alar ligaments, the apical ligament, which sort of goes straight up and down, and some of the other ligaments that live in the front above the atlas. I suspect that what we'll see over the next year or so is both procedures blending into one. Right now, we'll generally start patients off with the below the atlas procedure because we know that we just have more data on its safety. And if that isn't getting the patient all the way where they need to go, then we'll start adding in the above atlas procedure. But again, I suspect over the next year or so, those 2 will blend into one, and they'll all be done at the same time. given the safety we're seeing of the above atlas procedure. In addition, we're also just now getting to the point where we feel really comfortable in dialing in, getting to all the structures up there. Again, there's no textbook that we can go to look at this stuff because what we found is none of those textbooks are really all that accurate when it comes to how these ligaments feed into each other, because no one's ever looked at this. I mean, you can sort of take a cadaver and take the head off and look at this stuff, but you obviously have to destroy it to do that. So how it really exists in living people is not something anyone really knows, especially how it behaves when you inject into it. You can see some of these ligaments on MRI, but again, you're not seeing these fine connections between the ligaments that we see when we inject into those ligaments.
You know, this is what you get when you're working with Dr. Centeno and the Centeno Schultz Clinic, is not just clinicians following the trends, but researchers who are actually doing the research to create them. And by the time the science and the research, A, is done, and then B, gets to other medical professions, and then C, as you mentioned earlier, doctors, if ever, go through the training or retraining to learn something different, just about everybody else out there is going to be years, maybe even in some cases decades, behind what is really going on and what the sort of cutting edge research shows and tells. And that's really what you get when you work with Dr. Centeno and his team of doctors. Is again, I refer to Dr. Centeno as the Elon Musk of stem cells, and for that matter, orthobiologics in general. He's been doing this longer than anyone I know and has been more committed to really finding out what's working and what's working best, as well as what to avoid in order to not fall prey to the just pitfalls of what are obviously not good solutions in this category. So just a brief statement there. Let's get back to questions. Stacy Kaufman, we welcome back. It's good to see you. Missed in the beginning. Here's a question. If I have large upper C-spine pannus, and last DMX showed numbers near normal, but still have C1, C2, and C5, 6, 7 issues, should I avoid another PICL so pannus doesn't get larger? And what or which kind of ejections would you do for me?
Yeah, so Stacy, we haven't seen pannuses get larger at this juncture due to PICL. There's still an open question in my mind whether or not having a large pannus might reduce the ultimate efficacy of this type of procedure. So just that everyone understands what it is we're talking about, you've got the dens, which is the part of C2 that comes up, and then the atlas that kind of goes around that. And what we can see is in the back part of the dens, there can be some swelling there and or scarring that happen due to long-term instability, and that's called a pannus. And that can close the distance between that dens and the upper spinal cord and the brainstem. So we're not 100% sure how that factors in yet. We're still looking at that data. But the bottom line is that we don't see it get any bigger. Now, I would say that some of the newer above atlas techniques might be more effective in some of the patients who have a pannus, simply because sometimes when we're getting into that area on the below atlas technique, it can be very, very difficult to stay out of that pannus or the enlarged bursa that's there. So I'd say of the techniques we perform, the above atlas would probably be more effective for someone with a pannus than the below atlas.
All righty. This was submitted in advance by Maura McNamara. She asks, hi, Dr. Centeno. Are there any data records or results on treating Ehlers-Danlos syndrome, EDS, patients with craniocervical instability? Is the procedure less likely to work in this patient population? Are there any EDS patients who have avoided craniocervical fusion by doing this procedure? Thank you.
Yes, we have quite a few EDS patients that have avoided fusion to date. And we started looking at that. I think I talked about this maybe 4 or 5 or 6 programs ago. So we've looked at that data, or we started to, looking at EDS patients versus not, and the outcome from the PICL procedure. The problem that we ran into is that we started getting that data and sorting those people into 2 boxes about 18 months ago or so. And so we're trying to wait for enough people to have 2 or 3 PICL procedures in the EDS group so that we can compare to the non-EDS group. So we're probably still 6 months away from knowing that answer with a big enough sample in both groups where we're really comfortable, where we can use some statistical analysis and say these people are doing better than those, or they're doing the same, or the opposite. So the answer is yes, we have seen that. We are just in the process of looking at that, but it's going to take a little more time for us to get the information put together so it's valid.
All righty. Full disclosure, this is going to be a long one, but I'll ask it, and if you need me to repeat any of this, please let me know. This is from our friend Roger Chin. Hey, Roger. Roger says, I had the AstraZeneca vaccine 10 days after my PICL number 2. I suspect I had a mast cell activation syndrome flare as I got back to baseline after doing the Kilmus protocol. Presumptive MCAS treatment prophylactically before and after vaccination using H1 and H2 blockers. I think I'm back to pre-vaccination baseline, but I'm worried about the bad timing with my PICL. Would the histamine flare affect ligament healing? Also, on my PRP SCP treatment on my lower back and knee. Any concern with the antihistamines? Thank you for connecting with patients and the public.
Yeah, I doubt that there's a big issue there. When it comes to ligament healing, excessive inflammation isn't as critical as something like joint healing. So I think you're fine there. Now, it's hard to say, right? Because this is a new world with regard to new types of vaccines that didn't really exist before, RNA, DNA, etc. And in addition to that, how all that interfaces with a macrophage activation syndrome, and how all of that interfaces with a brand new procedure. So hard to say with 100% certainty, but my best educated guess would be that there's probably not an issue.
All righty. Roger, thank you for watching. Get well soon with all of that, and we appreciate your questions as always. Another regular viewer, Tom Walsh, he says, hi guys, has Regenexx reached the limit of healing with its current generation of platelet lysate? Is there another PL generation in the pipeline? Great question, Tom.
Yeah, Tom, I don't think we're going to, really, so what Tom's talking about is when we first started doing platelet lysate, we did a simple freeze thaw type platelet lysate. So we took PRP, we put it in a regular freezer, -20°C overnight, we froze it, and then we filtered out the platelet bodies, and just that freezing was able to lyse some of the platelets. But we soon realized that only a fraction of the platelets were lysing or breaking open with the freeze. So then we came up with other ways to lyse platelets. But at this point, I think we've kind of maxed out on what it is you can get out of those platelets, meaning your goal is to try to lyse 99% of them. And if you go from 99% to 99.5%, it's not going to make a big difference. But when we initially started these, we started using platelet lysate. We were probably only lysing about 1/3 to half of the platelets. So obviously, when you go from there to lysing, 90% or 95% of the platelets, it's a big, big difference. But probably not going to really make that too much better.
All righty, great is great. All right, Ryan says, can you perform stem cell and PRP procedures in the same visit to treat lumbar spine issues?
Yes. So we frequently, if what you're asking is, can we treat multiple areas when we treat your low back? The answer is yes. We can treat We treat a lot of patients with neck and low back issues. We treat a lot of patients who have low back issues and knee issues, etc. So it's not uncommon for us to treat multiple areas at once.
Using both PRP and or stem cells, I think is the essence.
Correct. Yes.
Perfect. Great. Thank you for your question, Ryan. Let's move on to Petra. Another question. She says, for how long after the PRP procedure should patients refrain from trigger point massage?
Really, trigger point massage isn't something that I'd be concerned about with a PRP procedure. Now, it's possible, for instance, that you have let's say a tendon getting injected that's attached to a muscle, and that tendon is very sore and beat up for the first week or two, and it hurts a lot. Hence, you might want to avoid trigger point massage during that time. But if you're getting something like a knee intra-articular injection with PRP, there really wouldn't be any rationale to avoiding trigger point massage at all.
Great question. Thank you for that answer. Roger's got a follow-up. He says, I had a consult with Regenexx in Vancouver, who surprisingly still does cortisone injections despite offering PRP. And they told me that PRP does not work if there's a complete ACL or PCL tear. I'm still waiting for an MRI to look at my ligaments. On April 1, I had SCP, not stem cells, which were reserved for my PICL. If I need stem cells for my knee, is it possible to do that with the PICL schedule every 6 months? Thank you.
Yeah, I don't know who Regenexx is in Vancouver, but so there's on the ACL, PCL, I think you said ACL, PCL, which would be knee. So in talking about ACL and PCL in the knee, it would depend on what type of complete tear you had. So there's really two types of complete tears. One would be that the fibers are damaged completely, and all complete means is through and through the ligament, but they're still together, in which case that could be treated not really with PRP, but it would be more bone marrow concentrate injected only under X-ray guidance, not ultrasound. And that's a very specific procedure that requires additional training, meaning you can't just walk into a clinic. I would estimate that we probably have about 50 US physicians, maybe 100, who can do that procedure well and understand how to do it. I would think there'd be very few people in Canada who would understand how to do that procedure well and can do it. Again, can't be done under ultrasound, must be done under X-ray guidance, and usually done with bone marrow concentrate, not PRP. Then we get into, there was a question about PICL and can that be done with a PICL procedure? The answer is yes, that can be done with a PICL procedure without too much difficulty. A lot of that will depend on how many cells are needed for the PICL procedure versus how many will be left over to do the knee, but usually that shouldn't be a problem.
All righty. I think you should be in good hands, Roger. Good to go on that. Thank you again for your question. Livia, also a regular viewer, hi Livia, says, can getting TC surgery during the PICL damage the PICL healing given the neck is more fragile after?
Can getting which surgery?
TC.
Tethered cord surgery.
Okay.
Yeah, we don't recommend tethered cord surgery at all for any patient pursuing or moving forward with a PICL procedure. That's a one-way street. Once that procedure is done, we are dramatically and permanently altering the biomechanics of the spinal cord. Now, there may be some people out there that need that surgery before or after, during, whatever, a PICL procedure, just because of the things that are going on for them. But we believe that those patients are few and far between. So we wouldn't recommend that procedure be done before a PICL procedure at all.
This is, again, a common thing. Roger sort of mentions it in his mention of who still does cortisone injections despite offering PRP. Here's a doctor now who's saying, tether cord surgery. Again, we reiterate, there's a difference between treating the symptom, kind of chasing the symptom through a surgery. Hey, if you cut it, you won't feel it anymore, or through ablation, if you burn it, you won't feel it anymore. Theoretically, the mission's accomplished, versus healing or repairing the tissue and the injury altogether. Those are two very different philosophies. And yes, sometimes doctors try to incorporate, because so many of you ask your local traditional doctors, hey, what about PRP? What about this? What about the other thing? Some of them are now just integrating this into their still standard symptom chasing mindset in order to go, yes, we do that. And unfortunately, fool you into thinking you're getting apples to apples type of care when nothing could be further from the truth. And that, I think, is part of these questions about what about surgery? And surgery, again, is a one-way street. It is irreversible and often may relieve temporarily some of the symptoms you're looking to feel better, but often comes with a very expensive cost somewhere down the line. And I don't mean financial, I mean physiological cost, like adjacent segment disease and others. So be aware. That's why we do this program. That's why we answer your questions, is so you can know the differences, the pitfalls, kind of the behind the scenes of what doctors know about what other doctors are saying. So let's continue. We've got the questions coming. So Livia says, that's the wrong one. We just answered that. Let's go to Megan, who says, is there a way to dissolve the pannus?
That would be pretty dangerous to do, meaning that that pannus is right there close to the dura, or the covering of the spinal cord. So anything we put in there to try to dissolve your pannus, which would be an enzyme that can dissolve collagen, would also dissolve away the covering of the spinal cord and or the spinal cord itself, and make a big mess. So yeah, no, that definitely would be a very difficult thing to do without hurting someone, and the risk of permanently damaging somebody and making that person a quadriplegic would be high.
Okay, let's stay away from that. Thank you for your question, Megan. Elizabeth Escardo says, thank you for such a great experience with procedures with you last Wednesday. Elizabeth, thank you very much for sharing. We invite and request all of you who have had positive experiences to share them down below, not because anybody needs more praise, but because these are great ways for real people to hear from real people the experience and results that real people get. It's easy for us to go, it works. It's more valuable for you to share your experiences with others. Doc, any comments on that?
Yeah, I would just ask if Elizabeth can allow me to discuss some of her specifics online. Elizabeth, I certainly understand if you're not comfortable with that. If you are, just put it in the chat box there on Facebook, because I think it may be applicable to some of the things we've been talking about with regard to pannus.
All righty, so let's keep going. We've got Stacy Kaufman, who follows up with, not understanding what you mean by above atlas procedures. If my C1, C2 are rotating and 5, 6, and 7 are staircased, how would above atlas injections help? And not sure about yes or no on another PICL versus injections being the better choice.
So yeah, we're talking about kind of two different things there. So as far as the lower cervical spine, C5, 6, 6, 7, then we can always treat that without obviously going to another PICL procedure. And lots of different ways to approach that, everything from injecting the ligaments around the nerves, injecting the disc, etc. Then we've got the upper neck, and whether or not we want to try to deal with the fact that there's a pannus. The above atlas procedure would allow us to inject some of those ligaments that don't interact directly with the pannus. If we go below the atlas, then that can get directly into the pannus. And a lot of times there's a large bursa there that'll just sop up all of the the fluid that we're injecting. And just to review, there's the two parts of the PICL procedure. There's the below atlas procedure that allows us to get certain ligaments. There's the above atlas procedure, which is newer, which allows us to get to different ligaments.
Outstanding. I assume you're okay on time. We got
Yeah.
a follow-up from Elizabeth, who says, "You are the best. Thank you." And then she did go on to say, please feel free to discuss. We have overcome so many hurdles together. 3 thumbs up.
Yeah, so thank you, Elizabeth. So really, Elizabeth has a pannus with a large bursa. And the first 2 times we did her PICL procedure, we hadn't done any above atlas work. I developed this whole procedure and I was thinking about doing it back then, but really didn't know the risks and didn't have that dialed in at all. So the first 2 gave her temporary relief because we were getting into the bursa and the pannus. Then on the 3rd procedure, we had started to dial in the above atlas procedure, and I was able to avoid the pannus and get directly into those ligaments that live up there. So again, that's the alar ligament, the top part of the alar ligament, and the apical dens ligament, and then going backwards, even into the top part of the cruciate ligament, which can connect into the transverse ligament. So it was just a different technique that allowed us to get into ligaments that would avoid getting into the pannus. And that 3rd one made a difference. And it was sort of proof of concept that for people that have a large pannus, that's probably the way to go. So we just did Elizabeth's 4th one. I focused on that above atlas technique because the below atlas technique in her just goes directly into the bursa. And so I did either side above atlas, was able to see beautiful flow in all the ligaments that I wanted to get into. And just for grins, I went below atlas for another time just to see what would happen. And of course, it went right into that big bursa. And that'll probably help give her some temporary relief, but that's not the thing that's going to really change her condition long term. So she's a living example of what we were just talking about, strategies to avoid getting into that pannus and its large bursa, which can really take a procedure from being a long-term game changer to really just a short-term effect.
Outstanding. And thank you for that, Elizabeth. Thank you for sharing and for the opportunity to share more with others. Real people's real experiences. It makes all the difference. Maura McNamara asks the question, does PRP or PICL not work as good on EDS patients, also patients with CCI from Lyme's? Thank you.
Yeah, I don't know that Lyme's causes CCI, meaning that we've got no information on that at all. Certainly we may have patients with EDS who get CCI, and I think as I was saying before, the answer is we're not 100% sure yet how EDS affects CCI outcomes. We're in the process of looking at that. We've got to collect some more data in order to really answer that question. I would say in the meantime that we've seen lots of people who have EDS and CCI who have gotten better with procedures like this. And as far as the presence or absence of Lyme's disease or Lyme disease, that is something that we can again, change the protocol for by adding in things like doxycycline, which is one of the antibiotics used to treat the Lyme spirochete, into the injectate to try to make that more effective for those patients. And that's generally how we handle that.
Fascinating. Great question. Thank you very much. Megan follows up, I'm hearing that prolotherapy works best at tightening ligaments. Does it make sense to do more of this, then follow with PRP stem cells to strengthen it?
Prolotherapy can work in tightening ligaments. It's a good solution for that. The biggest problem in the conversation we've been having around CCI is it's definitely not your go-to treatment for CCI. And I see a lot of CCI patients wasting a lot of money on traditional posterior prolotherapy injections into the ligaments back here and not getting much relief. But if we're talking about prolotherapy to tighten down a knee MCL ligament, for example, or to tighten down loose ankle ligaments, it's very effective and it works really, really well. SI joint instability, it can really help quite a bit in. So it just depends on what it is we're talking about and how that's used.
All right. Let's keep it going. Roger says, I love the fact that Regenexx has a holistic approach, function, not just pain, looking at other structures, not just addressing nerves for pain. Also, having unbiased funding for research is admirable. Regenexx is the SpaceX for regenerative treatments. Thank you so much for offering me hope and progress. I'm working on my sailboat now, hoping to get to the ocean the first time since the car accident 7 years ago. Your thoughts?
Oh yeah. Well, number one, you got to write me about your sailboat because that's great. I just bought a sailboat, so we can talk about sailboats. But in the meantime, I think what you're bringing up is important because I didn't know this about SpaceX, but apparently one of the reasons why they've been able to make so much progress so much quicker than the government has, i.e. NASA, is their prototyping, meaning that they are not afraid to have a spaceship blow up. And that was a big thing apparently for NASA. The culture of spaceships blowing up was something that NASA just couldn't do. So as you've seen, they're now trying their Starship, and they've blown up a bunch of them. But each one, in each iteration, they learn more and more, and they make it better and better. And rather than testing these things in a computer, they test them in the real world. And they've been able to make an immense progress that NASA never made at a light speed pace. And so, yes, we operate much the same way, meaning that the only way new procedures ever get refined is in actually treating patients and trying to see what works and doesn't work. And while randomized controlled trials are great, we do them all the time, you also need to gain enough experience to do a randomized controlled trial so it's not just a flop. So, the NASA approach would be you spend $10 billion on a rocket that doesn't work. The SpaceX approach would be that you blow up 20 rockets to get to a rocket that works and spend much less. And that's very, very similar to how medicine gets refined. And medicine gets refined by doctors treating patients. And there's no other way to do it. And yes, you can do a randomized controlled trial to make sure what it is you're doing really works. But a lot of times that's done backwards, where a bunch of university guys get together and say, oh, let's do this, let's do that, let's do a randomized controlled trial, before they have any idea if any of that stuff might work. And that's more the government approach or the NASA approach to rockets.
I'm going to pick up on, I can't let my cynical side not go unnoticed. One of the things I liked about what he said very much was basically that you have independent research, that you are not funded by a particular industry that would fund you specifically to do research to prove that their thing works, that's to their financial benefit. You want to comment maybe on, we talked last week about the Crime of the Century movie, and just how infiltrated some, maybe most, research is and influenced by the funders of that research, and how the sausage gets made in the real world?
Yeah, I think what you're bringing up is that, again, going backwards. And what I mean by going backwards is, for example, we saw a company a long time ago, not a long time ago, just a couple of years ago, that made a little device that was supposed to be used for bone marrow aspiration. And it was supposed to get a lot more stem cells. Now, the problem was that it was made by a guy who didn't even have any engineering background. And he just came up with this theory that this thing would get more stem cells. And then he put a patent on it. And then he paid someone to make it. And then he got a 510K clearance because it was similar to another device. But then and only then did he try to get some research on it to see if it actually worked. Turns out it didn't work. We tested it. Another researcher tested it. We decided not to buy it because it was a backwards development process. What should have been done was to try various things in getting bone marrow aspiration and then see which one worked better, and then from that maybe produce a device. Now, in our world, we've got a flexible lab platform, so we don't care how this stuff is processed. It doesn't really make a difference to us. We don't have these 510K devices. We're doing it all in our lab. So obviously, if it goes this direction or if the ball bounces that way, it doesn't affect us financially because it just means that we're going to do it this way versus that way. Whereas if you were creating a device, you'd be baked into one thing, or if you were trying to prove a drug worked, you'd be baked into that thing. And that's one of the problems, again, with medicine, is we get baked into these concepts that this expensive thing has to work. And then you get doctors who will support your concept. So this guy with the little device, he sure enough found doctors out there that were happy to tell other doctors that this thing was the best thing since sliced bread. He even found a research lab that would give him the answer he wanted. But then when independent labs like us tried to test it to see if we wanted to buy this thing, it flopped. And because it started with an idea and that thing had to work because of the investment in that thing. Again, our approach is the opposite. And that is, let's go ahead, see what really works and doesn't work. And if we need to change what we do, we don't really have a dog in the fight as to whether A works or B works. If it's A, we'll do A. If it's not A, we'll do B.
I think the simple philosophy is that some doctors, like at Centeno Schultz, choose people over profits. And many doctors, unfortunately, again, if you wonder where this source comes from, you can watch the movie Crime of the Century on HBO that just came out this week. And you could look back at books, for example, The Truth About the Pharmaceutical Industry, written by Marcia Angel, who was the editor of the New England Journal of Medicine. Who saw it from the inside closer than just about anybody could. So,
yeah, speaking of the crime of the century,
go ahead, Doc.
And I think I told you this. What Jason's talking about is the opioid scandal, which started with Purdue Pharma making OxyContin. And what I had told Jason via text was that the Purdue Pharma rep would come into our office. This is back in the late 90s when all this was going on, early 2000s. And he would guilt us as doctors into the fact that we weren't writing enough OxyContin prescriptions. He would show us, here's this university guy here and this study from this university guy that state that what you guys are doing is wrong. You need to write more OxyContin prescriptions. You're not treating your patients correctly. Ultimately, I threw this guy out of my office well before any of this stuff broke. He was no longer allowed in the office. Everyone in the office knew that he was banned from the office. Because what we were seeing as doctors was when we put people on this stuff, they got addicted immediately. Now, what he was telling us was that was impossible. His university doctors and their studies were showing it was impossible to get addicted. But it didn't make sense to us, nor was it consistent with our experience. So when he wouldn't stop being so obnoxious, he got thrown out of the office and banned from the office.
Check it out. You got to watch it. They'll invent new names called pseudo addiction. It's not real addiction. It's just like an addiction. Okay. And like Dr. Centeno said, the salespeople will tell the doctors what to do. And because there's such a separation from, I'll say, the bench and the bed, as in the research bench and the clinical bed that people are on, that is in such different places that the doctors on the front lines have learned to trust the bench, to trust the researchers. And it doesn't hurt that there's so much additional stakes and vacations and other speaker fees that go along with it that just get certain doctors to go, you know what, they must be right. They wouldn't be this nice to me if they weren't.
Nor does it hurt, and it's not so much the case anymore, but back in the day where, literally it was really interesting. I mean, many of these pharma reps were right out of the Miss America pageant. I mean, it was really interesting to see how these reps were picked. meaning that they understood that physicians at that point were mostly men. They understood very clearly it was difficult to get their attention, and they played that game like a fiddle, and they still do in different ways.
On that note, let's keep a few more questions. We'll wrap it up in just a moment. Lorian Sunshine Weirda asks, hi, this is Sunshine. I have a large panis as well. I will be out in 4 weeks for my first PICL. You inject above atlas. She goes on to say the same thing twice. So that's her comment. Doc, any comments on that?
Yeah, again, having this other technique as part of the PICL has been very helpful for us. It's allowed us to adjust in many ways. One of the ways we talked about with a panis, another way would be if we can't get optimum flow because of the way things are just positioned for that patient or other issues, we can have another option to get a different type of flow pattern from a different angle into a different part of the ligament. So it just gives us a lot more flexibility to make sure that that patient walks out of the office getting the best procedure we could possibly give them. And that's something we didn't have the ability to do 2 years ago, for example, as we were just starting to understand all of this.
All right, and let me clarify. She did follow up in her second. Her question is, will you inject above the atlas for her first procedure?
Yes.
Okay. Simple as that. That's all of our questions for today. We want to thank you for joining us, and always bring your questions. As you know, we're here each and every Monday on the Centeno Schultz Facebook page answering your questions. We want you to have the power you need to make the right decisions. Doc, let's wrap up. Today's show is about the difference between prolotherapy, platelet lysate, PRP, bone marrow concentrate. Let's summarize. What do people need to know? And again, I'll ask to, I know a lot of people go, I want this, I want that, I want the other thing. Maybe just sort of throw in, why is it important for you, the doctor, or whichever doctor they choose at Centeno Schultz? Shouldn't it be sort of up to you to sort of make the recommendation for which one is going to be best based on your clinical experience? I'll leave you with the last words.
Yeah, so listen, as we talked about, these things are different. We've got prolotherapy, which is an old technique, which involves injecting something that will cause a brief inflammatory healing response. We've got platelet-based treatment like PRP and platelet lysate, which is basically acts as espresso shots for the local repair cells. And then we've got more stem cell-based treatments like bone marrow concentrate. And when it comes to that, we're talking about putting cells on the ground that can oversee the repair response, and then, at the end of the day, turn into the bricks and mortar. Now, all of that needs to be chosen by someone who's got a lot of experience in what works and what doesn't in that particular problem. And I think what Jason's talking about is we'll sometimes see patients who get fixated on, I need this because this guy who has something like me had it and it seemed to work. I think the thing you need to be careful of there is making sure that it's the right treatment for you, because there may be differences between you and that other guy that haven't been discussed or you don't really understand, that may make one thing good for him and something else good for you.
And there you have it, another great program. Thank you, Dr. Centeno, for really making the time to do this. I know whenever I try to schedule with your scheduler, you're packed. So I know this isn't something you have to do, but I know it's also something that you're passionate about doing, which is giving you, the viewers, the ability to ask your questions, to really learn the details of not just the answers to your questions, but really how to think about these things the way experts, researchers, doctors, scientists, and I'll dare say, the doctors who have the most experience in this field with these procedures. You get the inside scoop by being here each and every Monday with us. Make sure to click the subscribe button. So if for some reason we're a few minutes late or you can't make it, you'll get a notification that we are live, and these shows are always on replay. So if you miss it, that's okay. Just come to the page, you can watch the replay. Lastly, if you are wondering whether you have coverage for your next procedure at the Centeno Schultz Clinic or anywhere else on the Regenexx network for that matter, you want to go to regenexcoverage.com. There are up to 8 million people of you out there that have coverage through your employers directly because they understand the value of thinking about healing versus just treating. And they have contracted with the Regenexx network specifically to give you access to this type of natural healing approach. We hope you'll take advantage of it. If you, anyone you know, are interested in learning more, you can either go to Regenexx Coverage or you can invite them to watch our program here each and every Mondays. On behalf of Dr. Chris Centeno, I'm Dr. Jason Deitch. Thank you so much for joining us. Bring your friends, bring your family, bring your doctor, or whoever else you know would be interested in learning more about taking back their power when it comes to their orthopedic conditions. Till next week, thank you for watching. Appreciate it. Stay well. Be kind.